Sir, please start the presentation. Thank you. We are live now.
Hello. Hello. Good evening, everyone. I'm Dr. Bhavna Saraswat. I'll be presenting the law case for today. So, a 10-year-old girl, first by birth order, born of non-consanguineous marriage, resident of Bandra and hailing from Lucknow, brought by mother with complaints of neck pain on and off since 1 month and bilateral lower limb weakness since the morning of day of admission, decreased sensation over bilateral lower limb and abdomen since morning of day of admission. Pain. 1 month ago, child had pain over the neck and upper part of back in the midline, just pointing to the region up till scapula. Insidious onset pain, dull aching. Earlier there was no radiation, not associated with any restriction of the movements, no association with coughing, not causing any limitation of daily activities, no diurnal variation. The pain lasted for 4 days, relieved on some symptomatic management, and a few days later again had pain for a few minutes. Now, since the past 3 days, the child is having persistent pain radiating to the right shoulder. On 4th of April at 10 a.m., while the child was at school, she had sharp pain radiating to the right shoulder.
सैंडविच कौन सा अच्छा है आपका?
Pallavi madam, please mute everyone.
After which the child developed weakness, which was sudden onset, symmetrical, involving both the lower limbs. Child could not move the toes, ankle, could not get up from sitting position. Both proximal and distal muscle involved with complete loss of movements. Child could not maintain the posture in sitting position and fell sideways, after which she could not get up from the supine position, could not move her trunk sideways. The weakness has been static since then. Child could, however, move all her fingers, had grip of her hand intact, could move her arms above her hand, and could move her neck in all directions. Child also complains of not being able to perceive any sensations over the bilateral lower limb in the form of not being able to perceive the feel of her cloth or any touch or pain sensation being given by her attenders. Loss of sensation was up till the level of her nipple. This was associated with not being able to appreciate fullness of the bladder. She had no complaint of dribbling. She has not passed stools in the past 5 days, and after this, the child was brought to the hospital. In the course of her hospital stay of the past 5 days, there has been no improvement or worsening in the weakness or on the sensations. There's no complaint of any altered sensorium, seizure, drowsiness. There's no history suggestive of any cranial nerve involvement. There's no history of any recent trauma, no history of Cox contact, no history of any bone pain, fever, no history of any recent infection, recent vaccination, no history of any rash, no history of similar complaints in the past, and no similar family history. Child currently is completely immobile and catheterized. There's no significant past history. ANC was uneventful. Birth and developmentally, the child is normal and immunized till date. There's no significant family history. Summary.
Okay, so let's start with this pain 1 month ago. What is the age of the child? 10 years, yeah. So pain over up neck and upper part of the back, insidious dull aching. This was for 4 days. So when this child came to you at this stage for 4 days of neck pain, what would be your thoughts? You don't know anything later because this is that time. So you don't know about the neurological weakness and all that, right? At that day, what would you think?
If there was any like one muscle spasm could be one thing that could be causing the pain, or if it was in a particular location or pointing to a particular site and the pain was sharp shooting kind of character of a pain, maybe some radicular pain could be pointed in that. If there was any history of trauma at that point of time, that could have caused the acute pain.
Anybody else? Anything else? So, how would you differentiate these which you said? So, one you said muscular pain, one you said radicular pain, and one you said trauma. So, how would you differentiate it on that day? Anyone else wants to try?
Pain due to trauma will be localized to the trauma side, as bruising associated. Uh, Radicular pain involving now will be sharp shooting pain. Then, muscular will be relieved on massage.
Muscular pain will be relieved on massage or application of local if there is some relief.
In general, muscular pain, the patient feels better when the muscle is pressed. And traumatic, obviously, there will be history of trauma, right? And what happens to radicular pain when you kind of palpate in that area?
Worsen with the child will
So nothing should happen, no? So nerve pain shouldn't be changed in intensity based on you feeling. So somebody has sciatica. If you palpate the thigh or the leg, the pain won't change. So the pain changes, if at all, based on the origin of the nerve that is being compressed or being caught wherever. So if there is a movement at that joint, so in sciatica, when you have a hip movement or a lower back movement, the pain may change. So similarly, this area, if at all, it may change with spine movement, but not with a local thing. What else is peculiar? See here, because you have a history of subsequent neurological problems, you are giving a DD of radicular pain. What I'm asking you is, you are in your busy OPD, cough, cold, cough, cold, cough, cold, cough, cold, and somebody comes with neck pain. How are you going to think of radicular pain that time? So what other feature, one more thing I thought will tell you that, oh, this looks like. It's severe and constant. So the disproportionately severe to any of your local findings or anything. So that's the thing that might make you suspect. Sorry.
I think whenever there is a pain, the most common cause is inflammation, and that is associated with swelling. So this child is not an inflammatory pain. That is out. Now, what else could it be? Vascular pain. Vascular pain is a very localized to the arterial supply. So that's not right. Another is the neurogenic pain. If it is the neurogenic pain, then generally radicular pain, which has a shooting character. This is dull ache. So it's not a neurological pain. So now you have inflammatory pain, vasogenic pain, neurogenic pain. Could it be psychogenic pain? 10-year-old, okay, many problems, stress, anxiety. Okay, so we keep that in mind. We're not rushing to call it psychogenic, but I'm just giving you 5 types of pain: neurogenic, vasogenic, inflammatory, seem to be out. Psychogenic may be at this side. Okay. And then fifth one what? Dull ache. When do you get a dull ache? I'll give you an example to think. I have an abdominal pain which is dull ache. It's not spasmodic, so it's not intestine ureter, but it's a dull ache. Where is dull ache coming from? And dull ache comes from an enlargement of some organ. Okay. So some organ is involved here. So what kind of organs are involved here? Okay. Had it been a lymph node, you would have seen a swelling and much more localized. This is not very localized. Therefore, I start wondering whether really it is a muscle pain. Therefore, dull edge. And why should be a muscle pain there like that? So imagine now, I have a catch in the muscle. We call it catch. What does it mean? My muscle is in spasm. But the pain is due to muscle spasm. But the question is, why has got my muscle into spasm? So it is protecting something underneath. When abdomen has a guarding and rigidity, that is spasm, there is an appendicitis setting in. So it's trying to control pain. So my first impression is something is happening inside. I don't know what is happening in inside. And that is far inside, not to be palpable, not to be visible. Therefore, straight away we start thinking, has it to do something with the vertebrae there? Okay, or the spinal cord itself. But it has not touched the nerves as such, or a radical as such. So we don't know at this stage what is it. Correct? And therefore, this pain is a muscular pain, but it is guarding something. Now, whenever there is a muscle pain, there is another type of pain. Inflammatory, neurogenic, vasogenic, psychogenic. But the fifth one is the referred pain. Whenever you have no clue at all what is the cause of that pain, because there is nothing there, I start looking at whether it could be a and typically myocardial infarction. Okay. And you have a knee pain when the hip joint is involved. And you search the knee. So this could be a referred pain as well. Okay. So at this point, we know that something is evolving. What is evolving, we don't know. It could be a referred pain, but referred from where? Whenever there is a referred pain, it means that the afferents are being shared by many. So that's why the myocardial infarction pain is also good, because the afferents come from different areas and meet, and that secondary neuron is becoming common for all. So the pain is felt here, pain is felt here. Okay. Sometimes the myocardial infarction would be felt in the neck too, but often mandible, etc. So could it be a referred pain? Now, if it's a referred pain, then it has to be some afferent nerves involved somewhere, where we don't know. So at this point of time, we would say that something is evolving, we don't know what is evolving. Then he gets better. Okay. If he gets better, at the most I could say some muscle spasm may have disappeared. Okay. But I don't know the cause. Okay. And therefore, then subsequently it has come up again, and now it is persistent. So something has evolved by now. So we don't know as yet what is evolved, but it's non-inflammatory, non-psychogenic. Stay with referred, but referred from where? Well, what are the areas involved there? Subcutaneously, there is nothing visible, so it could be a vertebra doing it. Okay, and posteriorly, nothing is seen as swelling, or there is no localized pain. But this is a little diffuse pain, so unlikely a vertebra. But vertebra still cannot be ruled out because we have a history only, we have not examined. And next to vertebra inside is the dura, meninges, and then spinal cord. So something is happening at that level. So far we won't know.
So which also teaches us that we should be a little open when we are asking about the character of pain. So don't just use dull aching as a essay, something you have to write, so you write dull aching. Not like that. You have to separate out between dull aching and sharp shooting and all that, right? And you should ask open questions instead of suggesting to the patient, okay, was the pain like this?
So if we are thinking of referred pain, for it to be referred, isn't it like very diffuse? Because she's saying that the pain has gone from neck all the way till up till almost the level of scapula, so it's pointing to that. So the pain is very diffuse for it to be referred. Like usually the referred pain, because when we are looking at a particular nerve root involved, like it will point to a certain location, I think.
Yeah, so we know of certain specific referred pains depending on their origins of the two organs, embryologically same, etc. All that we know. So you're right that the broader the pain and at a site which we typically don't know is referred, that is upper half of the back almost, then it is likely to be something local rather than referred. Yeah. Okay. Then the next complaint is that the child developed like, sudden onset symmetrical involving both legs. So, first of all, where is the anatomy here? Everyone think and tell us, and then we'll go to what is the pathology, etc. So, where is the anatomy of this weakness? Think whatever you say is right, because we have to speak here, make mistakes so that we don't make mistakes in the exam.
Anterior onset.
So whenever you have to, when you are learning, in your learning phase, whenever you have to think of an anatomy, also think of a prototype disease and see how that disease usually manifests. So what is the anterior horn cell disease that you know of? Polio. Okay, so how does polio manifest? We've not seen polio. All our whole generation has not seen. But if you have read, how does it manifest? Placid paralysis, unilateral or bilateral. Can be patchy. So in fact, I gave the answer. Symmetrical or not symmetrical? Can be anything. It can be either. So the point is usually, technically, polio is patchy. But that patchy you have to make out clinically properly. So this is too symmetrical. As the history suggests that it is below one particular level, everything is paralyzed, right? So that is a little less likely for anterior horn cell. Okay. Where else? So first go one step backwards. Is it upper motor neuron or lower motor neuron? Lower motor neuron. Okay. Why lower motor neuron? So again, we'll go one step backward. Suppose there is a lesion at, let's say, T2 in the spinal cord. This is upper motor neuron or lower motor neuron?
At that level, it will be lower motor, and then for the levels below, it will be upper.
At that level only it is lower motor. But below T2, so full body remaining, it is upper motor, right? So in short, whenever you are asked where is the anatomy, first think in your mind, is it the brain or is it the spinal cord? First think that way, right? Then in the spinal cord, is it at one level or is it at multiple levels, right? And then if you think it is lower motor neuron, then you come to anterior horn cell, nerve root, peripheral nerve, NM junction and muscle, right? Like that, right? So here, what do you think? Based on this description, do you think it could be central? First, give me reasons for that. Could it be a central brain that is involved?
Not common.
Not common, nahi, very impossible. Why? You're right. But remember, because this is the argument you'll have to use for many such cases in the exam. So you should be tip top with that argument. So you said that central is unlikely. I'm saying it's almost impossible. Why? So if it is central, the paralysis on one side or both sides? Paralysis on one side or both sides? So central should be one side or both sides? One side. So only left side ka brain is involved will give you paralysis on left and right both. It has to be both sides ka brain involved. Both sides ka motor area involved. Separately, which is not possible isolated, which means the whole brain is involved, which means the patient is not in normal sensorium, altered sensorium, seizures, so many other things, right? So that is why this is not central. Okay, this is your argument for most such cases, right? Now in the spinal cord, you have to decide one level or multiple levels. What do you think? It has happened at different times or it has happened at one time?
Because it has involved the whole thing at a given point of time, it is likely that it is one level that has involved everything below that.
Because even when you look at a GBS, which is involving multiple nerve roots, it takes a little time to progress, no? Whatever, 12, 24, 48 hours. So it can't be one time at multiple places. So one time is usually at one place.
I think we have rightly said that it's not central, but largely it's not central because it's acute. And had it been acute, oh, there would have been a disastrous manifestation, unconsciousness, seizure, etc. Could it be chronically involved central lesion coming with only bilateral lower limb? Because it's a bilateral lower limb. Straight away we would say unlikely central. You are right. But sudden makes it impossible central. But now I'll give you a story. Over time, I find that my both legs are not working and now I can't even move. But can it be happening central? When both sides, the pyramidal tracts are involved, right? This happens when there is a slowly growing hydrocephalus. Okay, and slowly growing hydrocephalus, so pyramidal tracts are going around, and those who are going to the legs are the first in line. They are inside. And therefore, occasionally, slowly enlarging head. But what is the peculiarity there? Headache and vomit. So again, no headache, no vomiting, no chronic, and no acute. So it has to be okay. And then symmetrical and sudden. Polio-like or either any other viral, polio-like viruses would have taken about a day or two to worsen. This is sudden. What is sudden? Again, vascular or neurogenic. Oh, okay. Can you hear me now? Yes. So we know that this has happened suddenly. So again, we start wondering, sudden is vascular or neurogenic or immunological. Three things happen suddenly. Trauma, of course, we are not considering here, but infections don't happen suddenly. So this is one of those. No, not vascular definitely. So could it be neurogenic? But there is no radical pain. So it has to be now inflammatory. Okay. And immune mediated inflammation. And therefore we shift our first focus, no swelling, etc., no inflammation. Now we come back to say maybe immune related inflammation. And therefore you have a myelitis, right?
I just wanted to ask, when we were saying that bilateral symmetrical could not be centered. For this, for the lower limbs, the representation of that, it's in the medial area. So if between the two lobes of in the medial something is slowly growing from parasagittal thing, and can it slowly progress and involve bilaterally?
That's exactly what Sir said, that if there is a hydrocephalus which is enlarging, then you have your lateral ventricles, then you have your third ventricle, fourth ventricle. So when all that starts enlarging, it can compress the fibers, but more importantly, the lateral, how is the motor area arranged in the cerebral hemisphere? Any idea? What is the relationship of the motor area fibers to the ventricle?
Lateral aspect of ventricle.
They are on the lateral aspect of ventricle. So you have the central parasagittal sinus, and then the leg fibers go over the ventricle on both sides, on the convexity of your hemisphere. So as your lateral ventricle increases, your leg fibers are likely to be compressed on both sides. So that is what happens in hydrocephalus. Now what you are saying is, suppose there is a midbrain pons medulla lesion which is compressing the tracts of both sides. So one is, a tumor will not happen suddenly, like 1 second and there is a paralysis, it won't happen. It will come gradually. Now, if there is something that happens suddenly there, like a hemorrhage or something, then there you have all your cranial nerves and your vital centers. So that patient will crash and will be very sick with multiple other deficits. So that is why it is not central at the place where everything comes close together, right? Yeah.
We move his upper arm as well. So where is the lesion?
We are thinking at the level of spinal cord somewhere below T2, because up until that everything is intact. She's able to move the neck, she's able to move the upper limb. So somewhere below the level of T2.
One of the upper thoracic segments is where your cutoff is based on this, right? Because your upper limbs are freed. So C7, C8, T1 all seems to be free, right? Okay.
And that is how now, when he said neck pain, looks like that it was a vague pain all over. That's why you said up to scapula, etc. Whereas the lesion doesn't seem to be involving cervical vertebrae, but down there, even upper thoracic are missing. So this is how the patients perceive. But as you rightly said, it is diffuse over, so we don't know where is the origin of that pain.
Then you've got loss of sensation. So now, I mean, we discussed why not anterior horn cell, but once you have a loss of sensation, then anterior horn cell is out, right? Why? Once you have a loss of sensation, why anterior horn cell lesion is out? Yeah, so anterior horn cell is only to do with motor, no? The sensory is piche se. So there's no reason why anterior horn cell should have a sensory involvement. So that is done. Now, where else will sensation be involved? Means at what level I am asking. So in muscle, sensation will be involved. If the problem is in the muscle, no. In NM junction, will it be involved? No. Anterior horn cell, we said no. So what is left in between? Peripheral nerve. So peripheral nerve is one where you have motor and sensory both. And otherwise, if you have a transaction of the spinal cord, then you have motor and sensory both, right? So whenever you have a sensory involvement, look at these areas, and you can't have so many peripheral nerves. So this has to be in the spinal cord. And now bladder and bowel. So what does that tell you, bladder and bowel involvement?
It has to be at the level of one particular spinal cord level. Because, and the bladder helps to differentiate between upper motor and lower motor this thing, lesions. Whether the bladder it's a spastic bladder or whether it is like there's an overfilling and retention. You can differentiate that. And the fact that the bladder is involved, it is not likely that the peripheral nerves are also, everything is involved all at once. If it was peripheral nerves, then it should have been in a upward manner, like things should have been affected one after the other. But the fact that the motor, sensory, bowel, everything is affected all at once, it's probably some spinal cord issue.
So bladder bowel involvement always points to the spinal cord. Now about differentiating between LMN and UMN, you are theoretically right, but it needs a lot of accuracy in the history. So what she was trying to say is that if by history you can make out overflow incontinence versus tiny frequent voiding, overflow incontinence would suggest that the bladder is absolutely paralyzed. So first it fills to no end, and then when it is over full, something keeps dribbling all the time. So that suggests a lower motor neuron. Whereas a spastic bladder, because of UMN, will contract. So little urine multiple times. But this history is very difficult in children. So based on this, separating UMN from LMN is not easy, right?
Summary: a 10-year-old girl brought with history of neck pain with acute onset paraplegia with sensory involvement with bowel bladder involvement without any cranial nerve involvement in a previously healthy child with birth and development normal and immunized till date is most probably a case of spinal cord involvement, probably at the level of T4. My likely DDs were: 1, acute transverse myelitis; 2, some compressive myelopathy, could like a malignancy or a Cox spine; and 3, some demyelinating disorder with long tract involved. So the pain, I did not feel that the pain should be entirely, like we should not take it into consideration only. Maybe it was some vague pain that was there, but then now also she's saying in the past 3 days the pain has worsened. It was present persistently. At the time of event when all of this, the sudden event that happened, she's saying that she had a very sharp shooting pain and then she fell down and she could not get up from that. So I did not want to just completely ignore that pain. And the pain, the fact that there was a pain, I felt maybe something was compressing from the outside. But because it was all symmetrical all at once, I didn't think it was more likely. So I kept it at a lower level. Because there's a long tract involvement and it is acute and there is a sensory level, there's sensory involvement, motor involvement, everything, all of that is happening. So I thought some demyelination could also be a possibility because everything is getting involved at once. Bowel bladder. Bowel bladder was something that, because of which I kept demyelinating in one of my last DDs because it should not have been involved in that case.
Could be a transient autonomic nervous dysfunction, even in GBS, but it is only transient, and for all practical purposes, what you said is right. No bladder bowel.
Actually, we wanted to bring the child, but she's been made immobile completely, so it didn't. On general examination, the child was lying supine with her lower limbs in extension with right upper limb in flexion and left in extension with catheter in situ with left IV in situ. The child was conscious, aware, oriented to time, place, person. Vitally, child was afebrile, heart rate, pulse rate was 90 per minute, RR was 24 per minute, pulses were well fed and extremities were warm. BP was maintained at the 50th to 90th centile. So with the upper limb, she was moving at her own will, that I've just mentioned at that one point of time. Upper limb, she could move at her own will. Anthropometry wise, her weight is 30 kg, length is 147 centimeters with a BMI of 13.8, impression thin. On head to toe examination, There was nothing significant. The head was normal in size and shape with normal eyes, ears, chest, and everything appeared to be normal. Spine examination, the spine appeared to be normal. There was no local mass, there was no protrusion, there was no spinal tenderness or any paraspinal spasm that was appreciated. There were no neurocutaneous markers also. In the systemic examination, higher mental function was intact. No cranial nerve abnormality could be elicited. Motor examination, the bulk of the muscles were bilaterally equal. Tone of the bilateral lower limb. Initially, when the child had come, I did not feel it was. Well, I felt the tone was normal, but over the next 2 days, I felt that there was hypotonia. But the upper limb tone was maintained. Power in the bilateral upper limb was more than 3/5 in all joints. She could move all the joints freely. But in the bilateral lower limb, it was 0/5 across all the joints. Neck, it was more than 3/5 in all the joints. Reflexes. Superficial, there was absent abdominal reflex. There was absent plantar. On the day of presentation, it was absent. Then 1 day later, there was flexor plantar response. Anal tone was reduced. And in deep reflexes, ankle was absent, knee was absent, but biceps, triceps, and supinator were all toothless. There were no involuntary movement, no meningeal sign. And for sensory, pain, touch, temperature, joint position, and vibration were assessed. All the sensations were absent below the level of nipple. At the level of nipple, there was some hyperesthesia which was present. But above the level of nipple and across the upper limb, the sensations were intact. And rest of the systems were within normal level. So
Go to the examination findings. One slowly. So you have hypotonia. You have a power of 3/5 and lower limb 0/5. Okay, upper limb 3/5, lower limb 0/5. And next slide. Reflexes. So absent ankle and knee. Okay. So hypotonia, power affected, and absent ankle and knee. So lower motor neuron or upper motor neuron? But we said it was upper motor na थोड़ी देर पहले on history. So अभी क्या? We were wrong on history. This is all lower motor neuron. So this is polio.
Can be in a spinal shock stage.
That is your explanation, spinal shock stage. But how will you convince the examiner that this is not lower motor neuron? You're getting what I'm saying? Your signs look like lower motor neuron, but in the exam, you have to justify that this is upper motor neuron. So how will you do it? Any thoughts? So what else happens with lower motor neuron? Besides weakness, muscle atrophy, wasting. It is a hallmark of lower motor neuron. Okay. So which is not there. You said bulk is fine. Okay. Then what happens to superficial reflexes in lower motor neuron? So unless the sensory system locally is affected, lower motor neuron, we said peripheral nerve. So unless it's a peripheral nerve issue, nothing should be wrong with the superficial reflexes. Whereas in UMN, superficial reflexes are altered or absent. Why is plantar absent here? It should have been extensor, no? If it is UMN, it should have been extensor. Why is it absent? Why is it absent?
because of the sensation, it's not perceiving anything, so there's no.
Very good. So every reflex has a afferent, center, and efferent. So because there is no sensation, plantar when you are taking, That afferent is only not going. So how will the efferent come? So extensor will happen if afferent is going and it is UMN. But afferent is not going. So there will be no reflex. So it will be absent, right? And you said there's some hyperesthesia. Yeah. So what does that mean?
That particular, the level of involvement which is involved, that zone, there is hyperesthesia usually. So probably because it was at the level of nipple, I thought it was peak.
Fine. So now tell us your final.
10-year-old girl with acute onset paraplegia with sensory involvement and bowel bladder involvement with absent reflexive with zone of hyperesthesia at T4 with history of neck pain is most probably a intramedullary spinal cord lesion, most likely acute transverse myelitis. It's still considered compressive. In the So in the acute stage, when the at the beginning of the injury, everything gets affected. All the lesions. It's no upper motor, lower motor का वो differentiation because all the afferents are affected actually.
Anybody? You also said rightly, what is spinal shock? So who is in shock? And why? So normally the impulses which come from the top, the cortical impulses, they are all inhibitory in nature. Okay. So they kind of control the spinal cord. Okay. So the brain is the boss. So it controls the spinal cord. It inhibits the spinal cord or controls कि ज़्यादा गड़बड़ मत करो. Now brain is cut off. Spinal cord has become the boss. So spinal cord is in shock. Arey, I am the boss. I don't realize this. So it takes some time for the spinal cord to realize that there are no influences coming from top. Then when it takes over, you will get all the UMN signs, right? That's the concept of spinal shock.
So initially we thought that it was acute transverse myelitis and we wanted to give high dose steroids. But before that we wanted to rule out. So we did a radiological intervention, and then on CT actually there was a kyphotic deformity involving the dorsal spine with anterior and central wedges, compression, collapse of the entire D2 vertebral body with abnormal prevertebral, bilateral, paravertebral, and anterior epidural soft tissue component. So suggestive of a Cox etiology. But actually, one thing that the reason that I took this case is on examination, on history, everything up until that point, we thought that it was like an acute transfer because the event was so acute. But when we saw the Cox thing, if it was something that was going on for a long time, why would it present acutely?
I think as Sir was hinting in the beginning, that pain which was there for a while, that pain now, suppose you look backwards. So there was pain originating from that vertebral erosion, which was being guarded by the muscles. So that is the guarding pain of the muscle. So that history, so a pure distinction between a transverse myelitis and this would be that in a transverse myelitis, that 1 month ka pain and non-specific things wouldn't be there. Transverse myelitis would come out of the blue suddenly, which is transverse myelitis. Here, that 1 month history was now representative of this. Why the neurological deficit sudden is when the vertebrae collapses. At that moment, it knocks off the spinal cord. So that is like a immediate thing. So that happens in 1 minute as a neurological weakness.
Even in a TB spine, for example, sometimes there is a sudden worsening, and that is because the arteries are involved. And the arteries at that level are circumcial, and therefore you will suddenly get a bilateral rhesus in a child who has a TB spine coming up slowly. So in this child, something happens suddenly, and that's why he get that. So retrospectively now, 1 month was a long story for transverse myelitis, but the signs were like transverse myelitis. So transverse myelitis like was a complication of some vertebral disease. Okay, and that is how we go by that. See how small little things would like that. When we started discussing first 4 days of that dull ache, we never thought we were going to hit a transverse myelitis. But finally we had signs of transverse myelitis. So now we know that this was a complication of some vertebral lesion, and now that has suddenly worsened, right? Pretty interesting. Many times you learn the retrospective. Okay. I did not say all that, but when we are discussing first 4 days, we never thought of any neurological things to come up. So I think that was a good sign. Good.
So, which brings me, in your spine examination in such cases, anyway, it is very important. You said everything is normal. How do you look for spine tenderness in these Cox cases? One is, of course, you look for a gibbus. What is a gibbus? What is a gibbus? Extra prominent spinous process of the vertebrae is a gibbus. In other words, it's like a hump where it should be a smooth curve. So that hump tells you that the anterior portion of that vertebrae, something has happened. It has flattened or whatever. That's why it has become like this. If it is normal like this, it has become like this because the anterior portion has gone down. So the posterior one is jutting out. That is what is a gibbus. So you look for that. How do you look for tenderness? So you are supposed to do a rotatory movement of the spinous process. So suppose this is the spinous process. You have to attempt as if you are rotating the vertebra. So you have to apply pressure like this on the side as if you want to rotate it. And that elicits tenderness which is there at these joints. What do you call that joint? I forget the name, but joint of the vertebra to the ribs. Yeah.
We got an MRI done that was also showing a complete destruction at the level of D2. After that, they just sent a cough workup and everything, nothing came out to be positive specific. We have not done the decompression was planned by neurosurgery. They have taken her up today. So when they do it, maybe we'll collect something from that side. But otherwise, we did a general thing only like the venous cord and all of that. Just, we were looking for any lymph nodes, nothing. We could not find anything to look for this thing. We found it.
Regular lymphadenopathy and cervical lymphadenopathy also, sir. So we have sent biopsy of that also, sir. What is said to come in? Microbiological evidence.
Good to have you with us. So basically, yeah, so when you are going to do surgical treatment in such cases, then that tissue only will give you the microbiological diagnosis. But short of that, you must always look for TB elsewhere. So chest X-ray is a must. Look for any lymph nodes. Your GL for AFB is a must. So all that routine you must do. Plus you try to get from that tissue as well, right?
I think a TB spine diagnosis is difficult to prove, but more difficult is to decide whether we should go in surgically or not. And there is always a risk of either sudden vascular or immune mediated complications. And once that happens, the recovery may be questionable. And therefore, the surgeons would opt to go in first. The physician feel that anti-TB treatment mostly might control it. I suppose both can be right or wrong, and therefore we need to counsel the parents. Okay, TB spine patient without neurological problem looks otherwise all right, and the parents will be uncomfortable if you say surgical intervention. At the same time, we will have to sound them to say that it may be a good idea to go because it will prove diagnosis one and it will also prevent further complications. And today's surgery is not dangerous. Okay. And I think therefore one would opt for it even when we have a good anti-TB drugs. That would be the large thing. Of course, if there is a paraspinal abscess, etc., it's an emergency. But even here, one could have considered to avoid complications retrospectively. So that's another way you would explain.
You want to tell us some indications for surgery? As in 1, 2, 3, which are like clear-cut indications for surgery?
Let you know.
Sir said when you pick up a TB spine just because of the deformity but not much neurological involvement, obviously you depend only on medications. But when there is a sudden compression and collapse like this, then maybe, like he said, you choose between the two whether surgery will help in faster recovery of the neuro deficit. But it's a difficult decision.
2 year, 2-2-month-old boy, second by birth order, born of non-consensual marriage, hailing from Nanded, resident of Navi Mumbai, Muslim by religion, Sheikh by community, brought by mother with chief complaints of increase in head size since 3 months, tremors in lower limb since 2 months, frequent falls since 1.5 months, and vomiting since last 4 days. Child was apparently all right 3 months back when mother noticed progressive increase in head size disproportionate to growth of rest of the body, which was associated with difficulty in wearing clothes. Initially ignored by mother as she thought to be normal growth, mother then noticed tremors in both the lower limbs, which was associated with increasing intensity and frequency. Noticed by mother when the child was taken on lap, not occurring when the child was sleeping. This complaints, the child was taken to a local practitioner where he was told to have some calcium vitamin D deficiency and was prescribed vitamin D in glass bottles to be taken for once a week for 6 weeks and calcium supplementation. Mother also noticed that child was having unsteady gait associated with frequent falls. Initially, the child was unable to run, followed by unable to walk, followed by unable to stand. Currently, the child is able to stand with support and roll over in bed. Complaint of vomiting is 2 to 3 episodes per day, non-projectile, non-bilious, containing undigested food particles, non-blood stained. There's history of decreased oral intake, history of decreased activity, and history of irritability present. There's history of preterm delivery and significant NICU stay. There's no history of fever, no history of seizures, no history of abnormal eye movements, no history of tightening of limbs, no history of altered bowel bladder habits, no history of swelling at the back, no history of any focal neurological deficit, no history of fall or trauma, no history of TB contact. Child was admitted for the above complaints in outside hospital for 3 days, where some investigations were done. CSF analysis was done and child was told to have some brain infection. The neuroimaging was done and told to have some increased fluid in the brain and was referred to higher center for further management. Past history, one admission at 1 year of age for pneumonia for 4 days. Child required O2 support and NEBS received IV meds. ANC is still significant. The age of the mother at conception was 33 years. Mother was registered. 6 USG scans were done, which were told to be normal. All the TT injections were taken. IFA supplements taken. There's history of hypertension in mother at 3rd month of gestation, where she was started on antihypertensive and stopped after delivery. There's one admission at 7th month of gestation for severe pain in abdomen, following which she had spontaneous vaginal delivery in the hospital itself. There's no history of fever, no history of GDM or hypothyroidism, no history of any blood transfusion. Birth history, the child was preterm 28 weeker, normal vaginal delivery, birth weight of 1.5, cried immediately after birth. There's history of NICU stay for 1 month in view of preterm. The child was kept on O2 by hood. Feeding was initiated by RT feeds. Child was given powdered milk. The child was discharged on day of life 40 on 40 spoon feed of expressed breast milk. Discharge weight is 1.8 kg. There's no history of neonatal seizures or meningitis known to the mother. No history of neonatal jaundice. Actually, the mother doesn't have the NICU records, nothing. Child is immunized till date, till 1.5 years of age. Developmentally, all the development milestones achieved before this illness were appropriate for age. Right now, gross motor. Before illness, the child was able to run, but currently the child is able to stand with support. So DQ of 34. Fine motor, the child feeds self from the cup. Rest of the development domains were not affected. So my impression is gross motor regression. Diet history, the child has a calorie deficit of 500 kilocalories and protein deficit of 8 grams. No history of similar complaints in family and belongs to upper middle.
So around 1 year, 10 months child. And then at 2 year, 2 months, this mother notices that for last 3 months, there is increasing head size. So what are your thoughts on that?
It could be a slow growing mass. Fluid. Either fluid or mass. Brain. Fluid could be because of obstruction of the fluid could be because of obstruction of the tract or somewhere, or it could be something that is compressing and hence fluid is accumulating, or overproduction of CSF due to some reason.
Okay, good. So fluid or brain, we said one of the two reasons for a large head. For fluid, she gave some reasons. Either there is a obstruction to the flow of fluid or there's overproduction. Now, if there is overproduction is usually very uncommon. So we'll keep it little lower down. If there is obstruction, then we have to think whether it is congenital or acquired. So what do you think? This is congenital or acquired? Acquired. So now we have to take this further, that acquired obstruction to the flow of CSF can happen due to what? We are saying acquired and we are saying obstruction to the flow. It can happen due to what things? Very good. So meningitis can cause. So in TBM, you get basal exudate and you get hydrocephalus. So meningitis can cause. Or it could be a sequelae of old meningitis. Now the problem is here, do you have a history to suggest that this child has gone through meningitis? That is now. That is now. What I'm trying to say is, how does meningitis come clinically? Fever, headache, vomiting, irritability, acute episode. So has that history been there in these 3 months? It's not been there. So how do you take this further?
Some mass within the ventricle, so ependymoma, yeah, some slow growing tumor that is caused there.
A periventricular SOL which is causing obstruction, that's your acquired cause. Any other thoughts? So one we said was that meningitis root, one is that mass root. Any other? Yeah, so aqueductal stenosis is blockage to the flow, which is usually congenital and would become obvious even earlier. It wouldn't wait till about 2 years, right? So just like meningitis can block, hemorrhage can also cause a blockage and it can lead to hydrocephalus. But the whole point is, in this story, we have to decide when, if at all, such things could have happened, because there is no obvious story of any such thing happening.
I think if there's an obstruction to the flow, then barring the aqueductal stenosis, which this child has only last 3 months. So it's an acquired. If it's an acquired, it had to be accompanied with many other things. For example, around third nerve, around the aqueduct or around the lateral, further down fourth ventricle, there are a lot of structures there. Okay. For example, if you have a cerebral tumor, then you must have a symptoms of tumor before even a hydrocephalus comes. If you have a meningitis, again, symptoms of meningitis before hydrocephalus. So we need to start every time the story as this child was completely well prior to the first symptom. Now, if we don't ask upfront this question, the parents miss out on some vague fever, loss of appetite, nobody weighs the child. So irritability, okay, small child is irritable. So we must ask that upfront. Then this has happened slowly. So what happened during that time slowly? Was he eating well? Was he playful, active? Or had he lost some weight? He should have had some story to account for an acquired hydrocephalus. Neither the mass nor the meningitis. And therefore here we are not sure what is exactly happening, but subsequently she is saying vomiting, yes. But it could have come up much earlier. Is it? No. So that's also not directly related to that. And decreased urine output, okay, that all is a later unrelated to thing. So at this point of time, we cannot pinpoint why this hydrocephalus has come up, right? So decreased absorption also might cause that. But that is a venous problem. And therefore, that would have presented with encephalopathy. So for all practical purposes, this is an obstructive hydrocephalus. But we have on the history nothing to suggest where is the obstruction and why is the obstruction.
Hypervitaminosis D. So, correct. So possible. So first, let's take it further. That we call it as pseudotumor cerebri. So there is a raised ICP looking like a tumor, but there is no tumor. But that raised ICP is increased fluid, or the substance of the brain, there is increased pressure. What I'm asking is, does it cause hydrocephalus, hypervitaminosis, or does it cause a increase? What do you think? Does it cause hydrocephalus? No, it doesn't cause hydrocephalus. So it will not come with a large head. So if there were symptoms of raised ICP, one of the possibilities you would think is hypervitamin.
Most of the presentation is rather acute and short term. Okay. Except the obesity, for example. Obesity has a pseudotumor cerebri coming up slowly. So, but that is without enlarging of head. In fact, the head is not enlarged, but the tension has increased. Sometimes you would see as a drug toxicity as well. So, but all that is ruled out. But a good thought that could it be really a pseudo tumor, but not pseudo hydrocephalus. Right?
Anjali has mentioned that the vitamin D here was given later. But anyway, our main thing is wouldn't have come with increased head size. Okay. Now, just for theoretical sake, we also discussed the other limb of increasing head size. Okay, is it the brain matter which is increasing? In some storage disorder which is giving rise to a large head. So why is this not that? We are to guessing that it is hydrocephalus. Why is it not megalencephaly? From the history, what do you think? Excellent. Developmentally normal child up to this 3 month back, right? So all those megalencephaly disorders are storage disorders, neurometabolic disorders, where there will be some developmental affection over a long period of time. So that has not happened. So this is not that, right? Okay. Now this mother has
One kind of a mass that you see, especially in a small infant, is a subdural hematoma. Of course, in old age, that is not uncommon. Of course, that in an infant may come with a bulging fontanelle, irritability, looking like some mass, and a subdural comes up slowly. Okay. And why does subdural come slowly? Subarachnoid comes acutely. Intracerebral hemorrhage is disaster, but subdural is slowly. Any idea? Subdural is a venous bleed, and the rest of them are arterial bleed. So the subdural slow collection, then large, then irritability, headache, vomiting. But if you miss, then the other hemisphere is also in it. And then you will get multiple infarcts everywhere because of the compression. Subdural gives you certainly some time to act. But if you miss that, then you have a bilateral hemisphere involvement.
okay, now of late the child is having unsteady gait with frequent falls. This is since means in this 3 month period.
1.5, 2 months.
1.5, 2 months, sorry, unsteady gait and frequent falls. So, so what could be the meaning of this? So again, that tremors also we have to understand, and this unsteady gait also we have to try and think and analyze. So what could it mean? Different possibilities.
Maybe hydrocephalus something.
Get the hydrocephalus. Now we have why would he have a unsteady gait? Means we are learning how to analyze that. Then we'll connect everything. So corticospinal tract getting affected will lead to what signs in the lower limb? Will it lead to weakness? Will it lead to spasticity? Spasticity. So spasticity leads to unsteady gait. How does a child who's getting slowly spastic in the lower limb, how does that child present? Scissoring is at the end of the thing, but in the beginning, suppose the legs are getting tight, then what will happen? Difficulty in diaper again is when they are smaller. This is a 2-year-old. So tripping and falling are the one of the possibilities, because what happens is your foot is getting plantar flexed because of spasticity. So you are unable to clear the ground. So you are going to trip and fall, right? Depending on whether it's symmetrical or asymmetrical, you could have a limp also, right? So these are the symptoms of increased tone. Then you have paralysis. So if you have paralysis, then you will have difficulty in walking, right? And unsteadiness would mean it could be a balance issue as well. So we have to ask history whether at this stage, because you've said finally unable to walk and then unable to stand. So was it a power issue? Was it a tone issue? Or was it a coordination issue? On history, we can try and find out. So as in somebody who can move his legs while sleeping, there's no power issue. You get my point? We didn't ask that.
No power issue. The mother is saying even the tone was not increased. The mother is not giving any complaint, but the mother is saying I, the child when the mother tried to pull when the mother tried to pull the child to stand, the child just used to take his limbs off the ground. He was not able to bear the support.
The sleeping position is able to move his limbs. Okay. Okay.
When you're considering ataxia, don't forget that it could be a posterior column as well. So just keep that in mind. And it could be even a ear problem, a vertigo. So all of them will say, I'm unstable. So just get more details every time to see whether there is any sensory loss anywhere, posterior column, or whether it's episodic. Okay, when you move the neck or body, you suddenly feel vertigo, but if you are stationary, then possibly you're stable. So some such details would make us know whether it's a cerebellum involvement.
When you would make him stand, he would cry? No.
The child was active and it was good. Now the child, like when the child present was very irritable. It was not like not, we couldn't even examine the child on presentation. Like was not, it was very crying. He was crying all the time. The child being crying. He was
Very irritable child now. So this complaint of unsteadiness followed by frequent falls, followed by inability to walk, as per her history, there is no big power issue and no big tone issue. So it is probably just ataxia, but whether that is good enough to make him unable to walk, we are not able to explain that. And then now the irritability. So last 3-4 days there is history of irritability and uh,
well. Earlier, when everything started, the child was active, mother is saying. But when the increased, the tremors have increased in intensity, the child has become more irritable since then. So it is gradual over 1.5 months.
that could even be raised ICP and irritability. But of course, the vomiting history is only last 4 days. Otherwise, we would have thought that gradual irritability, whether it's raised ICP.
I think when we are discussing cerebellar affection, there are motor tracts also around. In fact, a classical cerebellopontine angle issue has a pyramidal tract involvement on one side, and of course, you may have a sixth and seventh also coming there. So you will have to be clear whether it's really an increased tone that we are talking about. If that is so, then around the cerebellum, you have also pyramidal tract going down. Whether that is causing spasticity is one possibility that way. But history is now not easy to interpret like this. And if the child feels unstable even sitting, then I know it's more like a cerebellar problem and not a tone problem additional, right?
Summary: 2-year, 2-month-old boy, second by birth order, born of non-consanguineous marriage, hailing from Nanded, resident of Navi Mumbai, informed big mother came with complaint of increase in head size since 3 months, tremors and frequent falls since 1.5 months, with significant ANC and birth history, with regression of the gross motor milestone in a completely immunized child is most probably a case of acquired hydrocephalus secondary to can be meningitis or intracranial.
So when you said meningitis, you mean meningitis now or for 3 months?
Like maybe it was, but then there was no symptoms. Like earlier, all maybe it was missed. The mother didn't notice the symptoms. The mother noticed only when it involved the tract and the child developed tremors and other.
I think TB meningitis as the age advances presents as a meningitis without encephalopathy. This child has no encephalopathy. But a younger child is likely to have meningoencephalitis because there is easy immune responses coming up out of the basal, exudate, and tuberculin sensitization. Therefore, the question is, I remember Dr. Udani, who did a lot of work on neurotuberculosis, used to coin a term which is not accepted nowhere, but he used to talk that he has seen walking, talking meningitis. What he meant was there was nothing else wrong except a hydrocephalus. Now, it's only he who could have seen that. None of us have seen walking, talking meningitis. Our meningitis don't walk and don't talk. Okay. So just the point is to call it meningitis today, but slowly developing meningitis like TB or fungus may just produce, but not at that 2 years of age. 2 years of age, he would have gone down within a short period if encephalopathy, etc. So we are not very sure about that, nor we are able to put our finger on intracranial SOL, most likely cerebellum, but we have no other things to go. What is more important is why only lower limbs tremors? Any thought of that?
I thought, in fact, weakness could simulate tremors when he's made to walk or, bear weight. So temporarily there would be some, but he said that even in the lap it was lower limb tremors that we can't explain at all. So just for your knowledge, on a similar note, when newborns are given prophylactic antibiotics for some time pass reason, and if they were to develop meningitis, that meningitis gets half treated, and they come at 2 months with such a hydrocephalus, which is due to the meningitis which was missed, which is what she was talking about, not at 2 years, right? So it's one very important reason why, as residents, pediatricians, doctors, don't give prophylactic antibiotics ऐसे time pass में in a newborn. Either be sure that this newborn needs antibiotic or be sure that you are not giving antibiotic.
And I think such an infant at 2-3 months of age is sent for hydrocephalus only. But when you go into detail, right from birth till 2-3 months of so-called hydrocephalus, he's not doing well. He's irritable, he's not feeding well, he has not gained weight well. And I recall on 2-3 such situations when the history suggested a persistent chronic meningitis with hydrocephalus. What it turned out to be was a large multiple brain abscess, which is another complication of an irrational use for a short time of antibiotics. So I think that is, but as he said, at 2 years that looked unlikely. This would not have been a chronic meningitis which is missed. So likely, let's see what it is.
On examination, the child was lethargic. On examination, child was lethargic. When the child arrived, a febrile pulse was 110, regular in rhythm, good volume, equal on both the sides, no radial or radiofemoral delay. Peripheral pulses well felt. Respiratory rate was 28, regular. Saturation was 99%. Extremities were warm. BP was approximately at 50th centile. Anthropometrically wise, weight was 8.5, which was less than -3 standard deviation. Height is 84, which is -2 to -1 standard deviation. MUS is 13 centimeter, which is -2 to -2 standard deviation. Head circumference is 51.5, which is +2 to +3 standard deviation. Weight by height is -3 standard deviation. So my impression is severe acute malnutrition with macrocephaly. On head to toe examination, those enlarged head with thin build. The anterior fontanelle was open. It was bulging, non-pensatile, and no breathe was heard. Posterior fontanelle was closed. There was shiny scalp. Dilated veins were present. The sutures were still separated. McEwen sign was negative. No sunsetting. Pallor was present. face, spine normal, no neurocutaneous markers. There's no spinal mass, no skin muscles were normal, and genitalia was normal. On CNS examination, cranial nerve examination, all the cranial nerves were normal. On motor examination, the tone was also normal. Power was more than 3 by 5. You only got reflexes. Bilateral knee and ankle were brisk. The upper limb reflexes were normal. The bilateral ankle clonus, plantar was extensor. Uh, I couldn't elicit meningeal signs in this child, but the child was irritable. Cerebral signs couldn't be assessed. Rest of the systems are within normal limit.
So we want you to interpret these growth parameters. Means all that -3 and SAM and all that is so standard, you all ratify and just, but what is the meaning of all this? Sir wants to know, when did this child's problem start? You have a history of 3 months of large head. Otherwise, as per history, you said milestones were normal, everything was normal.
Milestone gross motor is not normal.
Now, that is after the illness.
Before it was.
So till 1 year, 10 months, according to you, this child was bang normal, right? Now, as per this, when did this child's problem start? As per this. Okay, why do you say acute? Weight is more affected, but height is also affected. So height doesn't get affected in acute. Yeah.
84 centimeter would be somewhere around 1 year and a half, so like 18 months, 20 months. So going by that, the history matters.
So she's saying that if you accept 84 as within the range for a 2-year-old, as on the little shorter side, but it's okay. We don't have any previous readings. This was a preterm who was 28 weeker, 1.5 kg. So 84 can be taken as normal. So in that case, your 8.5 also has to be considered in the context of that 1.5 kg at birth, right? So even that, you cannot give it the same significance which you would have given to a term baby, right?
Was it a full term 1.5 kg or preterm? So now the point is, what are the risk factors for this baby already? Let's not worry about what has happened. But if you now see this baby retrospectively at birth, what problems you might expect in the next 1 year to come, right from birth? You get my question? Then we could say whether the present situation is related to that. Okay. So what are the problems of such a preterm baby with 1.5 kg? So is it appropriate gestationally or not appropriate? Appropriate. So one thing is good, that there is no fetal restriction of nutrition. What is likely to happen neurologically to such a child?
It is known to be in preterm.
One is intraventricular hemorrhage. What else? Sir is asking till 1 year, what all things you might, it's possible that this baby can get into. Okay, apnea of prematurity, then bronchopulmonary dysplasia, tynopathy of prematurity.
One point in discussion, symptomatic otherwise. There is no history of anything going wrong. You are all right. You gave the right answer, but that would have come out with some symptoms. Okay, this is asymptomatic. Now add to that, some injury happened at birth, transient, caused a damage. Apparently, the mother feels there is nothing wrong. So your blindness, okay, or breathlessness, all that is gone. So what could happen at birth that would be easily missed and may present with a poor school performance? That play. Till then I'm all right. So one is hypoglycemia. Hypoglycemia is easily missed. Okay. It may not cause a seizure or a sudden neurological event, but hypoglycemia not treated, but it did not go further down to just impair this. That is one. Could there be a hemorrhage that has been missed? And now hydrocephalus is being seen.
It can be, but there's no records. Like mother also don't have it. She has,
Thing that
but it is too late. Too late.
no, so we'll discuss that. It's not too late.
Would a breastfed baby at about 1.5, 2 months get some intracranial hemorrhage? I'm not trying to say how bad is the breast milk. Don't try. But could breast milk be related to some problems? Exclusive breastfeeding. If this baby was not given vitamin K, exclusive breastfeeding babies are likely to get a later part of infancy at 6 weeks, 8 weeks, even an intracranial bleed. Of course, we are not discussing all that. We are looking at what could have been asymptomatic, therefore missed. And one is a metabolic like hypoglycemia. Sometimes the polycythemia, if this was so, then that also could have been missed, and you can see a delayed milestones, etc. But his milestones have been normal. So possibly he has not had any damage out of that preterm. Okay.
I want you all to focus on this slide and tell me if something strikes you. We have a 2-year, 2-month-old child who has come with a enlarging head for last 3 months. What on this slide strikes you?
If it was starting at 2 years old, the AF should not have been violated. I think. So it should have happened early. So the insult is earlier, 18 months is earlier, before the closure of AF.
So she said that you normally expect latest closure of AF by 18 months. In fact, even earlier. A closed AF cannot be opened back by a hydrocephalus, and that too such a wide AF. So that means this process of hydrocephalus started long back, right? That is the interpretation from this straight on. Okay.
Could it be hypothyroid? Delayed closure of anterior fontanelle. So what is against that? No, they were there also, their head looks a little large. So what? Okay. Here, of course, you have a measurement also. But hypothyroid is the first possibility when there is a delayed closure of that. Would malnutrition itself cause a delayed closure of fontanelle? After all, bones are not growing, no? The child is not getting length much. Severe malnutrition. The head is also not growing. Nothing inside the brain, but open fontanelle. Now add to that, you have a hydrocephalus. So should malnutrition cause delayed closure of fontanelle? And the answer is no, but the inner table must have closed already, but the outer may be open. But otherwise, and why not? Malnutrition children are small in length, they have not grown well. What makes their growth? Head grow all right. And the answer is the nature will prevent brain from getting damaged. Let the length go bad and let the weight go bad, but not. So whatever little calories, proteins he gets is only for the brain to develop. So malnutrition never causes any problem out there.
So all this large AF and all this. Come on, someone, I want someone from your to answer that. I was going to ask, then I forgot. Why massive ones is negative? Very good. Fontanelle is open, so there's no question of doing massive ones. Raised ICP nahi, raised ICP hoga, but you don't do massive ones. So what is the other name for massive ones? Cracked pot. So first there has to be a intact pot, which cracked. Then you get a massive ones.
When do the sutures close down? Anterior frontal, yes. I'm asking suture. Crack is sutural separation. When does the suture close down? Anterior frontal, yes. Metopic, when sutures close down almost at the end of growth period, adolescence. That's why in pediatric practice, you will get massive ones mostly, even in older children, but adults, of course, not. So anterior fontanelle approximates to be closed, but the sutures are not permanently closed, and sutures are closed permanently only towards adolescence. But can there be a microcephaly and raised ICP? Microcephaly, it is not large, but raised ICP. Which means brain wants to grow normally, but the skull bones don't allow the brain to grow. What kind of illness is? So that is only one microcephaly with raised ICP.
Okay, so now come.
Summary: 2-year, 2-month-old boy, taken by birth order, born of non-consanguineous marriage, came with complaints of increase in head size since 3 months, tremors and frequent falls since 1.5 months, with significant birth and ANC history, immunized till date, developmentally appropriate before the illness and gross motor regression over the course of illness, with severe acute malnutrition, with macrocephaly, with diet deficient in 500 kilocalories and 8 grams of protein, with signs of wide open bulging AF, was most probably a case of acquired hydrocephalus secondary to perimeningitis. We had done a neuroimaging for the child when the child came. It was suggestive of communicating hydrocephalus with periventricular ooze. The counts and everything was within normal limit, but in CSF, we could found 210 cells, which are polypredominant. And the child has proteins is 51 and sugar is 25. The corresponding HGT was 110 something. The sugar is- No, RBC. Okay, it's not RBC. The child has undergone the PTV surgery along with VP shunt insertion right now from the neurosurgery. So the child is in post-op period right now. We are still finding out the exact etiology, like we are not yet communication. Lateral ventricle, sir. Third ventricle as well as fourth. Yes, as well as fourth ventricle with thinning of the surrounding cerebral. Thinning of the surrounding cerebral parenchyma. Okay.
Moderate dilation of the bilateral lateral ventricles with Evans index of 0.52, third ventricle as well as the fourth ventricle seen with thinning of the surrounding cerebral parenchyma. There is an artifact noted in the dilated ventricles with symmetrical prominence of the bilateral choroid plexuses without any focal lesion. But I think mainly the lateral ventricle. No, basal exudates are not mentioned. There's mass effect that is seen in form of severe thinning of the and upward bowing of the cortex callosum.
So the point is that, we when we were discussing on the earlier slides and about the prematurity, and sir asked whether anything could be silent. So one thought process was whether because this was a premature baby, some hemorrhage at that time which was not noticed, and whether which has led to a slowly progressive hydrocephalus since then. They have noticed the enlarging head only for the last 3 months. That is what we were thinking of as one possibility. In the CT scan, you have to look at, so if you're looking at aqueductal stenosis, up to third would be large, but fourth will not be large. So that is your differentiation that this is due to congenital aqueductal stenosis, which it is not. Your CSF picture is a very, very mild abnormality. Means, first of all, theoretically, you will call it meningitis because the sugar is low compared to this and you've got 90% polys. But it's almost as if you've picked up meningitis on day 1 or day 2 of meningitis in a 2-year-old. It's not even day 2, day 1, you've picked up meningitis. It is that mild an abnormality. So that cannot explain the hydrocephalus. You get my point? So the hydrocephalus is obviously old and older, and this current CSF abnormality is difficult to explain.
I think even if you get polymorphs in CSF in such a child, it could have been a little blood coming into the system. So I don't think we will call it as infection at all. As far as sugar is concerned, could it be this child is starving a little and the blood sugar is also small, a little less? So your borderline CSF 110. That's very, very unusual. Okay. And therefore, all that means the meningitis is right now there. And the child is too good for all that. So look something there. Whenever you have such discrepancy, we may have to get back to history, get back to physical examination. It's not worth doing another CSF when everything looks all right. Otherwise, you will have to confirm also what CSF is, right? But that is quite. I'm sure this could have been possibly again an antibiotic administered very early for some reason, and a meningitis missed. Okay, and that time, and today you have only a hydrocephalus. But even then, it looks like it has happened pretty early in the infancy, and the child should not have a normal milestone. So there has to be some delay. At that age, any meningitis would have definitely some delayed milestone. So there are discrepancies. Uh, I think it's good that we discuss what is being presented, and you are presenting what mother has told you. You are right. But many times we may have to again and again confirm it. In our YouTube channel, therefore, I once decided to talk on, all of you say, history given by mother reliable. So I made a 10-minute video to say how do you make the histories reliable or not. Just to give a thought. Okay. And what I meant was that you don't take anything as told to you. You might cross question in different way and then say that. For example, milestones all right, but when did the holding head came? Okay. So all more detail. And it is difficult for mothers to even remember. Okay. So We will have to give an allowance to that. But surely don't go away feeling, I hope antibiotics are not on for this child. Antibiotics have no question. Okay, just you're not treating those polymorphs. They will take their own care. Where is the infection? That's not fine. And then, yes, uh, don't go by that. Okay, I think there is no difference of opinion there. There is no need for an antibiotic. Okay, you might send a CSF culture if you like, and even if that shows something, I will doubt whether it was contamination. I may not have done a second CSF report because
They put in a shunt. They've already taken up the child for surgery and put a shunt. So I'm saying they must have collected CSF that time. They didn't do it.
I think the only thing that comes to my mind is there is a condition called spinal meningitis, which means that meninges up there are not involved. I haven't seen one, but I've read about it. And then that spinal meningitis, then in that case, the CSF from ventricles and the CSF from lower down is different in your biochemistry and cell. But I have not seen anybody like that. But there is a concept of spinal meningitis. Especially in TB, it is known. It is recorded. One has to see thousands to pick up one spinal meningitis. For us, meningitis is all over, right? Yeah.
Okay, so we stop here. Any comments or questions from the online audience?
Rajesh, just a query. Could this very remotely be something like CMV or toxoplasma?
As in, you are saying congenital.
Yes. Of course, this child was otherwise doing well, no hepatosplenomegaly, but
Yeah, so there's no other organ involved at all, and
correct.
there's no calcification also. So to that extent, because no other organ is involved, seems unlikely.
Yeah.
So if we are, so basically the whole debate is whether we are contemplating that this hydrocephalus started around birth, and if
Yeah.
so, then higher than congenital infection would be the other issues like hemorrhage
Partially
missed
treated
or a
meningitis. Yeah.
meningitis partially treated or things like that, right?
Yes. Yes.
Okay. Chalo, thank you
Thank you very
everyone.
much.
Next Thursday. We meet next Thursday.
Yeah.
Thank you everyone. Thank you.
Thank you, Amdekars sir. Thank you, Rajesh. Thank you, all the children who presented and the online audience. Thank you.
Thank you.